called Hepazord. We had a Dr. Daly, when he did open heart, he wanted a PTT and a thrombin time after their surgery, and he wanted done with Hepazord. So what you would do is you would take the blue plasma, you would mix it with like so many milligrams, I don't know how many milligrams it was, of this white powder called Hepazord. You incubate it on the rocker. In hematology, they have a rocker for bloods, so it keeps mixed. And you do that for 10 minutes, and you centrifuge it, and when you take the plasma off, then all the heparin absorbed down into that white powder. And we did PTTs and thrombin times after every open heart. Well, after he left, the other physicians didn't want that. So the thrombin time is pointless. If they're on heparin, you can tell them it's going to be abnormal because heparin interferes with the test. So, but the registry a lot of times keeps on things that are still, like the micro. This is the first year a lot of people were telling me when I'd go visit the students in micro, they said, anybody know how to get that screen corrected?
Hit control. Scroll. Hold down control and use your mouse button.
Oh, control here?
Yeah.
And hit
down,
what?
And hold down control and use your mouse button. That usually zooms in, zooms out.
I don't know. I know Deanna was the whiz in our last class if the screen was. I'm not really sure how to get the screen. Yeah, I don't know. Anyway, so hopefully we'll be able to read. Anyway, the micro, I have to teach you a thing called biochemicals. And sometimes you'll go to the micro department and you'll know your biochemicals better than the text because they see if it's gram positive, gram negative, get the gram positive card, put it on the Vitek. Gram negative card, put it on the Vitek. And I have to teach you all the biochemicals because they say on the BOC you got to know them. So this is the first year they said, well, they keep wanting to go to your flow charts, and I said, because they have to know them for the registry. So micro, this is the first year, the students seem to be knowing more about the biochemicals than the techs working in there. So sometimes they expect, that's what we have issues with. I was in a meeting with them deciding what they wanted in microbiology for MLTs versus MTs when I was at my meeting, and I go every February for the clinical lab educator meeting. And everybody's territorial. No one wants to give up the content. They're the experts, so no, they got to know that. And you got to cut it down. If they're not going to be doing it out in the real lab, you got to start making adjustments because they're not going to see it. And so when people tell you, you don't have to know it. If you don't know it, you won't pass that test if they don't change it. It's not lab-based, it's theory-based. So, tell me what you know about the specimen for testing. Coag is probably the most critical that your specimen is the first thing that affects you negatively on your results. So why does it have to be 90%? Does anybody think why? It's a 9-to-1 ratio of blood to what was the anticoagulant? Sodium citrate. If you don't keep that 9-to-1 ratio by having a full blue top tube, you're going to have too much anticoagulant, and in the testing, it's going to make it look like the patient has a clotting deficiency. And because their proton PTT will be abnormal. It's because you had too much anticoagulant for the amount of blood. That's supposed to be a 9 parts blood to 1 part anticoagulant. So and I felt that phlebotomists deserve to be told why you're asking for a redraw. It is no fun to say go redraw and no explanation when that patient's not going to be happy you're coming back. So I always tried to say, hey, I need you to have a redraw of this purple top. Our rule is the hemoglobin, if it drops over 2, you have to redraw it. And that helped because then they understand you're not just telling them your specimen was bad, go redraw it. You're explaining why. It's our protocol. We have to make sure that it was the right person, that the drop was valid. Then the floor has to be involved. Hey, are they bleeding somewhere that you don't see? Did they just have surgery? Or if it goes up to did they come in hemoconcentrated? They didn't have enough fluids, so the minute you get them on fluids, then it's normal. So if you explain why to your phlebotomist, it's a team effort, then you're not like blasting them and making them feel like they did something wrong and you don't even explain it. That is a big deal. The other thing is hemolysis. This is something, I was in coag all the time, so this is something I saw every time I ran them. We're not supposed to run any hemolyzed specimen, but the one that won't be affected very often is a protime. So if you had slide hemolysis and it was a difficult stick, you'd run it and then you just flag it. You can write in 74 characters and say slightly hemolyzed, so at least the physician knows it wasn't a perfect specimen. But I noticed anytime I had hemolysis, and if you ever ran a PTT on it and you got a good specimen and you just wanted to see a study to see once you had it redrawn, the hemolysis will shorten a PTT up to 10 seconds. That's a big deal if you run it and it's hemolyzed. Let's say you get an outpatient or someone, we used to run MDL labs, all their coag on Sundays because they were closed on Sundays. And if you can't get that patient to be redrawn and they say go ahead and run it anyway and just put a disclaimer that it was hemolyzed, if you get a good specimen, it's going to be like 10 different. So that was something I noticed throughout my career, that the PTTs were shortened. It almost like it gets the clotting factors activated and they work really well. So there's a reason that you have certain anticoagulants, and what are the two labile factors? Why do you need to run them in 2 hours if you have them? What are the two labile that break down? And they're also the two cofactors.
5 and 8.
5 and 8. They're the ones in the boxes with 10A and 9A. Those are labile. That means they break down. You don't want to let it sit there forever. The other thing, you don't want to let it sit on the cells. If you're not going to get to it right immediately, spin it and remove the plasma and put it in a plastic tube. Usually plastic is better for coag than glass. Glass can activate quickly if you have, like not pouring over from a red top tube. In the day that we used glass tubes, it was really fast acting. If you have a red top tube, you're starting the clotting system, just the exposure of the glass to the blood, and you can think it's not clotting, but you try pouring that over and it's going to affect your blue top. So you as a tech need to be knowledgeable that you can explain to your phlebotomist why you need it. People then don't get mad if they understand why you're having them redraw. It's for the good of the patient. So you be the tech that is a team player and doesn't act like you're the top dog in the lab and make the other people feel like they're peons. We had one girl I give her credit, in 2009, we both had issues, Barb and I went, she would take us to task over every test question that was missed in front of the class. There's no way she could miss it. It had to be us. And we told her in our affective, both of us, if you do that with techs, point out every mistake that is made, they're going to let you drown one day. No one is going to want to work with you if you act better than them. If you are good, you should take it upon yourself. Like I had a student in 2013, she was great. She wanted to know how to fix and handle everything because then she'd help everybody else and wouldn't make them feel like they were this big. So don't think because you're good, no one will work with you if you act better than people. I will tell you that. The minute they can, they'll let you drown if you are having troubles. So what I'm saying, some of you get it quickly. Be the person that takes it to help everybody that might be struggling. Because there might be one thing they get really good that you don't, and you'll work as a team. And I always found that if you help someone else when you need it, they're going to help you. From the littlest person in the lab to the biggest person in the lab. And I remember one time we had a pathologist over at all of our departments, and the one head was treating this little Spanish lady like crap. And she would cut her down and point out her mistakes in front of the students. And we even had students come to us, we feel so bad for her. And I went to the head pathologist of that area. I said, how can you let people treat people like that? She had to go from full-time to part-time because of the stress. She had to go on antidepressants or anti-anxiety because of it. And she was a great tech. But she was Spanish speaking and she couldn't think quick enough to stand up for herself. So I observed all the negative, and I wasn't perfect by no means, But what I'm saying is, you have a choice to be the tech you want to be known for out there. Just like I tell my kids, you have a choice to be the type of people you want to be. Don't go out there and be like, oh, I'm so good, I'm going to show everybody. Be the one that helps everybody and brings up the level of your whole lab. And we've all worked with people like that in our other jobs. We know it. You've all had fellow students that you've been in other classes with. You know it. So it's out there. And I had 2 students that ended up doing that, and I had 2 guys said, your students are really knowledgeable, but these 2 let us drown if we're it. And it killed me because they were both good. But they used it to take care of their buddies and make the people they didn't think were good enough drown. You know, they go sit and read their book when they're dying with a workload over there. Our philosophy on our weekend, we were so good because we'd say, okay, I'll do your log. I see you're busy. Next time they're busy. Okay, you guys go ahead and go to lunch. I'll put on the stuff for you so you can at least get to lunch when we all can't get to lunch. And we had a great weekend because everybody helped each other. So that's what I'm saying, you guys. Make sure your phlebotomists understand why you're having a redraw. Don't just act better than them. They're where it all starts. Now, this is something I thought was interesting because the START 4, the MLA is optical density. It detects a clot as the density or thickness of the plasma changes. There's a built-in endpoint where they know there's clot detection. The fibrometer is electromechanical. As the clot forms between those 2 little probes at the end of that falls into it, that triggers that the clot is stopped. Well, so too with those little balls when you put them in the START 4. So if I asked, is the MLA which type? You'd say optical density. It's like a spectrophotometer in the machine where it detects the change as the clot forms. And the electromechanical, the 2 examples would be the fibrometer and the START 4. The aggregometer is something we're going to get into when we talk about platelet aggregation. Remember, it's like a spectrophotometer that measures the change in the platelet-rich plasma as you add an aggregator and the platelets clump together and fall out, it clears. And the percent of light that gets through is better. So that'll be coming up, and I brought the diagrams. How many controls do we run? And remember what were they? I didn't have any level 1 on the MLA, but what were the controls on the START 4 versus what were the controls on the MLA? We mainly did level, on your practical, 3. So there was actually a level 1. And then what did we run on the START 4? What were those controls called? And remember which bottle was which? Normal. So normal is which lid? Is the white. Because I, in my head, always used to think blue was the normal. The blue is the abnormal. So now in hematology, you're going to move to, they do 3 controls. Most of our patients are either normal in coag or elevated. It takes longer to clot. Well, in hematology, you don't know. You might have anemic patients, you might have normal patients, and you might have like polycythemic patients. There's 3 levels of control you'll run with Diane. A low abnormal, a normal, and a high abnormal. So you need to understand your control. Even though technically CLSI sets the standards for test procedures, you got to run a minimum of 2. But some departments will run more if they have patients both high and low. So think about if you have patients high and low, you're probably going to have high and low controls. Remember, don't let them, when you're a tech, this is the thing I'll preach in urinalysis too. I would have techs that would let urines sit there till they got more to run than 1 or 2. Well, urine should be refrigerated after an hour if they're not done. And they'd let them sit out 3 and 4 hours till they got a batch. I was a tech who always ran everything as it came in because I didn't want to get hit with stats from ER and then all of a sudden I have all this work I didn't do, now all the stat stuff. For the patient's sake, you should be running those urines correctly. They should be done within an hour, or if not, refrigerated, and if you refrigerate them, you let them warm up. Same thing with coag. If you're not going to run them within the 2 hours, take off the plasma and put them in the refrigerator. And usually they have plastic takeoff. You raised it? Oh, I'm sorry. Oh, what do you got?
The sun's on my eyes.
Oh, sorry, I thought, did something else happen because of your accident and I didn't know?
No.
Sorry. So we're not gonna do FDPs because no lab's doing them anymore. So, I don't know, are you guys okay with the sun on this one? Okay, some of these you should know because, so let's see what you do know. Tell me about the bleeding time, what's the key thing? What is it for first?
Platelet function.
Platelet function, and when else can it be abnormal where it'll be longer than 9 minutes? Not just if the platelets don't function, but if they're really low. Like a cancer patient, if theirs bottom out to 5,000 when it should be 140,000, or it's 150,000, they won't do the bleeding time test well because they're just not enough. Okay, and what is the key thing about the bleeding time that you can cause problems if you're doing it? What do you got to keep? What pressure?
40.
Keep it 40, and then what do you want to avoid when you're making the incision?
Scars.
Capillaries, any scarred, and it's tough to do someone that's swollen. So to find any area on a person that has edema, that is tough. That's hard to even draw blood because a lot of times even to find the vein, you almost got to try to push all the fluid out of the way to even palpate the vein. But the 40, and a lot of these I would say refer to your lab procedure, especially if it's one we've already done. That's the key thing, 40 millimeters of pressure, and make sure you avoid any vessels, avoid any scarred area, any swelling if you can. I remember having one, it was an elderly patient, and I could not get it to bead up. Every time I tried twice, and every time the blood would just dissipate under the skin. It was skin I could probably pull up, and I could not get a bead. So I tried to do it twice, then unable to do bleeding time. We had to type in, and then I had to refer it to the pathologist. We could not get it. So if it's below, I was kind of picky. I wanted it repeated if it was abnormal low or abnormal high, because it used to be our phlebotomist did it and we reported it. So anything abnormal, I wanted it done twice if I was going to be the one reporting it. Remember, it's your right. If you're the one reporting it, you want to make sure, and it's like a blood draw or someone does it, that it's not you, and it's abnormal. It's every right to have it repeated. The PFA 100. This I thought was really interesting in the book, so I copied it. And I tried to make some notes because I want you to see these cartridges. And it has little curves too, but I like my curves from Harmony better. So when we get to platelet aggregation, but this is the PFA 100, I thought was really good. You want to pass these two back? And I tried to highlight some key parts. I think some of you will get to see the PFA 100, so I want you to at least understand what it does for a platelet. See if there's 6, and if you keep just adding it to her, then I can paper clip them.
Okay.
And we can, I can't leave them in here because someone follows us probably. I don't know if you guys will have enough. You have enough? Okay. Look at, oh, I'm sorry. I didn't give you guys enough, sorry. So if you look at this page, it says PFA 100. I guess there's another company calls it 200, another one calls it Siemens Healthcare. We had a PFA 100. It's an in vitro method, which we know is outside for screening. It was really tough to turn the book. It was pretty fat to get it flattened on the thing. Screening platelet function in a more standardized technique than the bleeding time. The bleeding time, do you see all the room for error? If you press too hard, if you make the incision in the wrong place, if you don't follow your pressure. This, you did a blue top, but you didn't spin it. So you couldn't give it to the coag people to put a proton and PTT, and they've spun it and then go give it back to the PFA 100 people. It had to be a full blue top unspun first. And there's 3 cartridges, and if you look, they have a great table on the back. Let me put it on the Elmo. We only used 2 of the cartridge, and I'll show you why. We didn't do all 3 cartridges at St. Elizabeth's. We did I flagged the ones we did because you wanted it to distinguish, and I put in your PowerPoint slide what it meant if you were normal, what it meant if you were on aspirin or any product that had salicylic acid, and what it meant if you truly had a platelet function problem. So they were little cartridges you add the blood to. I don't know if it's 100 microliters or what, and you add it to both sides. And you have a little machine that reads it. And it probably detects some kind of clotting, and there's an endpoint of when you know it's abnormal. So there was one cartridge that had collagen and epinephrine, one cartridge that had collagen and ADP. And they're flagged here. On your front side, it says in there what the cartridges are. And so what I want you to know is, how do you know it's aspirin and how do you know it's a platelet function disorder? So we're going to underline those 2. So if you look, there was not consistency with the PGE1. I think it's PGE was, because we didn't have that one. It stands for prostaglandin E1. We used these 2. But there was inconsistency, but there was very consistent results here. So if you're normal, both cartridges will clot in the same time. I'm not going to ask you that. You would expect both of them to clot in the same time. But look what happens to sulfosilic or salicylic acid. It is abnormal with the first cartridge and normal when you do collagen ADP. And then look when it's a disease. If you look, these 2, I'm not really sure what clopidogrel is unless it's some kind of medicine. So if you look at these 2, so I want you to know this one and this one. And they could have added BS too if you want to add Bernard Soulier. Look, they're both abnormal. They're both abnormal when it's an actual platelet function problem. So what I want you to know for your test is, how do you know in the PFA 100 it's aspirin, or a drug that has aspirin in it, or salicylic acid, and that's when it's normal on the collagen ADP and abnormal. And then when you have an actual, so if you memorize, they're both abnormal if it's a true platelet function test. You only need to know it's abnormal with the first cartridge. So that's what, so if we go back, we'll kind of point out what I want you to know for the test. This is test 5 also, if you want to put test 5, because tomorrow's test 4. So it's normal with both cartridges. If it's abnormal with only collagen epinephrine, they're on aspirin. If it's abnormal for both, they have a platelet function. So that the bottom 2 is what I want you to know. And the reason people have gone to the analyzer is it takes away the areas of technique that sometimes affect the bleeding times. So everybody can do the bleeding time a little bit different. And so I hope some of you get to see it. I know whoever goes to St. E's will get to see it. I'm not really sure if like Breeze and Highland does have it, then I bet Breeze has it because they're sister hospitals. I'm really not sure about Memorial if they have it. But I think, in my St. Louis hospitals, I'm not really sure. But I think some of you will see it. Okay, this is the aggregation we talked about with ristocetin. These are the curves. I tried to point out the key pieces of the curve, and this is from my favorite book, Harmoning. I just think their curves are better on demonstrating when you're trying to understand it. So there's a curve on the back side we need to know too. That's why it's two-sided. But they show some curves on different abnormals on the other sheet, but I think harmony, when you're first learning, is the better curves to look at. It's funny how certain books remove things, and you gotta go back to other books for you to understand the process. So this, tell me, when would you order, and this is something you're gonna have to know for your test too. The things I have highlighted, we're gonna go over what you gotta know on the test. So I put test 5 on this sheet too. When do you order platelet aggregation studies? What has to be abnormal before the physician will order it? Think of your screening test. Why they do screening test. So which screening test would be abnormal and they know they're not on aspirin?
Bleeding time.
The bleeding time. Then you go to this. This is the hallmark test you go to when your bleeding time is truly elevated because you're not on any medication with salicylic acid. So this is the key thing, and what I like, I thought it even, let me go back to the sheet I just had. I think it even says, it even on the bottom of this, it tells you about ristocetin. So if you look, so that one sheet has stuff about aggregation too that is interesting for you to validate what we know. Remember we talked about using platelet-rich plasma, and you add the aggregators and you do it in a spec and you see if the aggregator worked. And look what it says about ristocetin. Is unique among the agonists or the aggregators in that its action depends on VWF and GP1B. Remember, that was the one aggregator that didn't worry about GP2B and 3A and fibrinogen and calcium. So that's something why we knew ristocetin was abnormal with Bernard-Soulier, ristocetin was abnormal with VWF, because that aggregator needs that. So the key things with aggregation, I'm going to flag the ones you got to know, and it'll be a matching. You don't have to draw any curves. You are going to have to know which are monophasic and which are biphasic. And so we're going to go over that. Some are such strong aggregators that they cause that release reaction and you can't even tell. It just goes one straight line, and that's monophasic. But some aggregators, which is why I pick on the back side of the sheet optimal ADP, you see the release reaction. So it's a biphasic curve. It'll go like this, and then it'll go like this when the release reaction occurs. So on your test, if you want to put, you're going to have a matching on which ones are monophasic and which ones are biphasic. So let's look at the aggregators. Let's look at your PowerPoint slide a minute. There's thrombin and epinephrine, and I even put in here which one causes what curve, so if it helps you to write them out so that you have them in a different format. Then there's ADP, and if you look at that back side of that worksheet, it gives you 3 strengths or concentrations of ADP. I only flag you on optimal. It's the best concentration for showing the true biphasic curve. So what we're trying to do here, we're trying to stimulate the aggregation. And when did we say aggregation was better? When the release reaction has occurred and you get all those granules released. Serotonin is, to me, pointless. So if you notice, I have a big X, because what happens there, and we'll go through each curve in a minute, it breaks up, the platelet clumps break up and dissociate. So how would you know they have a problem or not? So I don't even see why anybody would choose to use serotonin, so I don't have you know anything about that. Ristocetin causes a monophasic, and maybe if you want to write here, the only one that uses VWF and GP1B. So that'll reinforce. Ristocetin acts differently when it gets, they call it agglutination with ristocetin. It gets them to join together, but it only uses GP1B and VWF to do it. And then collagen causes a monophasic. So you would have to put biphasic. I could separate them out on the matching. And then I'll show you what we mean by and then we'd have ristocetin and collagen. So I don't care how you memorize them. If this format helps you better, I don't know if you can think of letters somehow. You know, some of them get mnemonics and they can think of it that way, but I don't know, RC and TO, TEO. But let's look at the handouts, and I'll show you what happens when you add the aggregator. So remember, this is only ordered if you have a true abnormal bleeding time or PFA 100. That you know it's a platelet function problem. So let's put the first one on. Let's look at collagen. And I tried to flag you. What's PRP stand for? Platelet-rich plasma. So we have 10% of light getting through. When you just take that plasma in a cuvette, put it in the spec, it's going to be pretty dark and it's not going to have much light shining through. Then you add the aggregator, so much, microliters to the tube. Then I'm sure there's a reaction time, you let it sit a little bit, then you put it in the spec again, and you see how much light clears. When you put it back in the spec, it is 85% of light gets through. So all those platelets clumped, fell out of solution, and it lightened. So a lot of light could get through. Well, it's such a strong aggregator, you can't tell when the release reaction occurred. So a monophasic curve, you cannot tell when the release reaction occurred. You just know it happened because you had such clearing that you had all those platelet clumps and they're heavier, they fall out of solution, and then you have a clearer, more light gets through.
You said you cannot see them.
The release reaction. Okay? So let's look at the other the monophasic one. Look at ristocetin. Same thing, it starts with platelet-rich plasma. You haven't added anything in it. And it's very dark and cloudy, so only 10% of light. You're reading percent transmission, and we've done that with hemoglobins too. Only 10% of light gets through. You add the aggregator. Can we tell where the release reaction occurred? No. It's such a strong aggregator, but almost 90% of light cleared. So it made them clump together, so you knew they had enough VWF and GP1B because you're talking about ristocetin. That's the only one that uses that. So those are your two monophasic. So let's look at our first combination. But you got to know them separately. They put them together, epinephrine and thrombin, but you have to know thrombin causes a biphasic epinephrine and optical ADP. Now you can see where the release reaction occurs. You start with your 10% platelet-rich plasma. You inject the microliters of epi and thrombin. Now you see the release reaction occurred here, and you have secondary aggregation. This one still cleared well, but it was only probably around 65 to 70%. But it had a biphasic curve. So if you think biphasic shows the release reaction. So it gets that secondary wave. Or two waves, if that helps you. Okay, so epinephrine, thrombin. I don't know how to help you with how to know it's mono or This is why I don't like ristocetin. Serotonin. Look what happens here. You add the serotonin, it drops to about, 18%. Then all of a sudden the platelets break back up, go make it cloudy again, and it goes back up to 10%. So I don't know what you gain by using serotonin. If that's what it normally does, if all of us are normal and it would does this, so I don't even have you know it because I don't see the point. It doesn't really show. Any true release reaction and aggregation. So you don't have to know serotonin. And the only ADP I have you know is the one that shows the biphasic. So optimal ADP, you see the release reaction in the second wave, and it gets to about 65 to 70%. So that's what you got to know for platelet aggregation. It follows in a true abnormal bleeding time or PFA 100. A true abnormal, which means you know they're not on any medication. And you got to be able to tell me which ones are monophasic, which is ristocetin and collagen, and which ones are biphasic, thrombin, epinephrine, and optical ADP.
Is it optical or optimal?
Oh, sorry, optimal. Yes, optimal. Okay, that one, I hope someday, if you ever get to work like Barnes, they might do platelet aggregation. They have a special coag area. They'll probably do factor assays. They'll probably do at least ristocetin, because that's a big one for von Willebrand's, and von Willebrand's is probably one of your most common deficiencies related to your clotting factors. So I think Barnes, anybody who might work at SLU Hospital, they have a special coag lab, and maybe a Quest. If any of you work at a reference type lab, they might do some platelet aggregation and factor assays. Your normal, typical, everyday lab is not going to do this, or any factor assay more than factor 1. Yes?
So you don't have one over there? Like, we're not gonna do this?
Oh, no. I mean, most labs don't even have it. And what the killer is, micro is a killer, because used to be, I tell the students, you'll get some fungus, you'll get some parasites, you'll get some mycobacterium. Now, hardly any lab, unless you're a specialty lab or a big time lab that they all feed to you, are doing any of that. And they're still not dropping it from what the students have to know, even at the MLT level. I even made the point, can't at the MLT level cut down the amount of fungus and parasites if no one is getting to do it in the normal lab. So micro is gonna be tougher. I'm on this listserv for lab educators, and I bet there were 20 posts about what are they gonna do about micro rotations, because everybody's going to this molecular diagnostic instrument called MALDI-TOF. And so it's so expensive. Most places like a BJC and SSM are having certain sites, and everybody else sends their micro to them. Well, if you have one micro site, how are you going to train all the lab? Because SLU has a lab program, Forest Park has a lab program, I have a lab program. In this Metro East area, that's why I'm trying to get my foot in the door to Barnes. Oh, and I want to tell you about that. I talked to the head of the Barnes lab again, because we were trying to go next week, because my sophomores, that's their last year, and they are not ready to handle us coming. So I told them as soon as he knows some dates, I'll let both you guys know. It is probably the best lab you'll ever see. I didn't think I'd see one in my lifetime. It is so impressive. So if you guys want, I'll let you know. If anybody wants to jump on board, we're all going to we're going to try. I'm hoping all my techs work either evening shift or night shift, so they can go, because every one of them wanted to go, and it can't be next week. He said, we're not ready to have you come. So I told him, just let me know. So I told him I would include you guys too, because we'll be in hematology, so you might luck out and be here, and if you don't have to rush off, I'm sure it'll probably be an afternoon when there maybe aren't as busy, maybe between a drop off from other hospitals. So anyway, it is incredible. And I thought it was incredible, and it wasn't even all the analyzers up. It is just incredible. And I think they went and had tours of the Mayo Clinic in Minneapolis or Minnesota when they were making it and designing it. And I got to see, when I first took over the program in '98, I got to do a site visit with a very experienced coordinator from Peoria. And she wanted me to go with her because I could go to the Mayo Clinic. And I saw my first robotic, and that was back in '99. The little robot would come and bring all the samples. It was on a track, and it would come, stop at your department, you take yours off, then go bring all, and I had never seen anything like that. So the Mayo Clinic must have a lab kind of in this order.
They have one of those at Boston.
One little robot?
Uh-huh.
I wonder what department, because my first line of instruments was at Christian, which is BJC, and then they had a line at Barnes, but I never saw a department that I went to that had, and I only got to go to chemistry in South Barnes. That is like a complex. I went to North Barnes for my student, then she had to go to chemistry at the South Barn, and they had different floors, different departments were in. So any of you that want to be in only one area, probably Barnes type facility will be your type of place. Most other places you got to be able to do it all, maybe except micro. So
If you're really are deficient, will your curve just go straight across?
you won't aggregate.
Won't see
So
anything.
what would you say the percent transmittance? I think that's why I don't care for serotonin. If you can't aggregate, it's going to look like that serotonin. Remember, if you don't, what happens when you don't get to more complete aggregation because you don't release all the dense and alpha granules? You don't have good aggregation. So what's going to happen to your platelet clumps? They break up and go back into solution if you don't ever get to the release reaction. So I think everybody will look like the serotonin. So that's why would you use serotonin? Because to me, that's how you'd be if you have a problem. So remember, you're not going to get, you're gonna either dissociate and stay where you don't have any platelet clumps, no aggregation of it. So you're still gonna keep a cloudy solution. And I'm not really sure if they have cutoffs. Well, if you only clear to 50%, there's a problem. I'm not sure. If you only clear to 30%, there's a problem. But I think the ones I chose are a little bit more clear cut because they at least almost clear to 70%. So they may have for each aggregator a cutoff. With factor deficiencies, wait one second. On factor deficiencies, it's usually, when we talk about, when we get to substitution studies, they say if it's a 50% correction, and I'll show you what I mean. On our test, I just make it completely go to normal if it corrects. But truly, they say if it is a 50% correction, if you had an 80-second PTT and it goes to 40 seconds, that's a correction. Even though, well, wait a minute, it's not 28 to 36. So I'll show you. I don't know if they have something like that. If it, at least gets clearer by double, I'm not sure they're cutoffs. So I hope some of you, I think this would be a really interesting one to see for coag. Yes?
When you use serotonin as a control, you know what's going to happen.
I don't really know what they use serotonin for, but to me, I think it looks like what you would do if you can't aggregate. So I don't really see how you tell anything. If it goes back up to 10% and that's what you started, how would you know if it did anything with serotonin? That's why I don't have you know it, because I don't see myself, without ever having done this test, the purpose of it. But the other ones, you can kind of see how you could tell a problem. Okay, so you're going to have to know that for your test. And you have to know what kind of plasma you use. Platelet rich, because when you do protimes and PTTs, what kind of plasma do you use? Platelet poor. You spin it fast when you're doing protimes and PTTs. You're providing the phospholipid or platelet source in your reagents. So when you're doing a protime and PTT, you want all that removed down on the Buffy coat. So you got to know platelet rich plasma, and you look for clearing, more clearing as the platelet aggregation occurs. So, what are the screening tests for platelet function, platelet problems? What is for platelet number problems? You do what? What's the screening test? No, for platelet number problems. What's the screening test? Part of a thing in hematology. CBC, the platelet count. If you're doing platelet function screening test, you either do a bleeding time
PFA.
or a PFA 100. If it's truly abnormal and you're not on any aspirin or salicylic acid in any other product, then you proceed to this confirmatory test. So this is an example of a confirmatory test. This isn't a screening test. So we already know with platelets, it's the platelet count and the bleeding time or PFA 100. Platelet count, so you know that's 150,000 to 400,000. And we already know you had ITP, acute and chronic, you had TTP, you had HUS. Those were examples of low platelet counts. A high platelet count, you already had essential thrombocythemia, or if you had if you wanted your red count elevated, your white count elevated, and your platelets, there's something called the polycythemia vera, which you'll get with Diane, okay? So that was under platelet disorders. Okay, so now tell me, and I don't know if you guys have, you're supposed, whatever symbol on your calculators to take it to the power, but I am going to give you a pro time that you have to give me the INR on your test, okay? So this, I think this is my last one. I don't know which book this was from. I think this was from Turgeon. Turgeon has some really good, I like her stuff too, but I can't find one textbook for coag that to me does it all. So you will have to calculate an INR. So you need either a caret symbol or you need to be able to take it to the power. And so we'll practice one. So anybody know what the INR stands for? Normalized ratio. And remember what it should be if you're in good anticoagulant therapy?
2 to 3.
2 to 3. Now, if you have something, like we said, it's going to be higher than 3. If you have repetitive blood clots, heart attacks, they're going to want it higher than 3. The normal average person just going on Coumadin, they want it between 2 and 3. Do you remember the formula when we went over it before? And it's on your backside. It explains international normalized ratio using the sensitivity index for each lab would have their control, their reagent of thromboplastin. You've got to read the vial or read the insert and see what the ISI value is. And what is the value of the INR? Remember? What does it do for the physicians?
Every hospital or lab has different values, so it makes it standard.
It standardizes it. If the physician knows their Coumadin level, INR, is between 2 and 3, they don't have to worry about adjusting it. If it's below 2, yes, they have to worry about either adding more or what might the patient be doing that's counteracting the Coumadin. What might they have to check? That the patient could be causing the problem of why it's not up to 2. The diet. So you got to make sure anybody goes on Coumadin, they should be talked about diet, what you avoid, because if you have too much vitamin K in your diet, the Coumadin is not going to work properly. So remember, it is the patient pro time. So if that helps you to write the patient, and then over your mean of your normal range. And we'll establish one. I think we're going to go with 12 seconds. The mean of your normal range, and then it's to the power of the ISI. That thromboplastin, that's like from 2004, that is probably like 1.82. But if you used Innovin, it was 1.00. So if anybody has the power, we're going to use 12 seconds as our mean of our range, even on our test. And then if the patient's pro time was 16 seconds, what would that be? So those of you, I know Krista has a calculator. I don't know if
I
you.
just wondered, did you find a pink one in the
There is one I put in the drawer over there.
That's
Go
mine.
look in the drawer. Look on the desk or in the drawer. I don't think Barb would have done anything with it. I put it on the podium desk, the teachers. And look in, if it's not on the top, look in the drawer. So what is this? Anybody? One. So 1.69 or 1.7. So what would the doctor do for that patient? Increase it, or they would say, check, and maybe we need to change your diet. What have you been eating this last week? And then everybody who goes on Coumadin should get a sheet of what to avoid. So if it's that close to 2, you might want to look at their diet. Because we have some that get in check right away, and then you have some that are coming back every day for a proton. They can't get it up to the right level. So if it's between 2 and 3, so let's do 24 seconds. See what 24 seconds is. So 24 divided by 12 to the power of 1.81. Or 82, sorry. 3.5. So now what does that tell the doctor? Their patient has 3.5. Lower the dose. So maybe have them cut the pill in half, or maybe have them skip every other day till they get it down to 2.3, 2 to 3. We had our panic range. Sometimes when you get into the real lab, they're going to have panic ranges. And we got talked to if we didn't call a panic. Because they could go back and see every panic and see that. And then we even had what you had to fill out. You had to fill out who you called it to, the name, what was the date, what was the time, and what were your initials. So they even had a thing you had to fill out. So if they say, oh no, you didn't call that panic, you can say, well, it says I talked to Katie on 12/3 at 2:15 and I called it. Then they know you called it and they're just trying to get out of that you called it. Panics, so the panic at our lab was 5. Every lab you work at is going to have a list of panics that you have to call to the floor. They're not going to, this isn't a panic. They're not going to worry about the patient bleeding. What is the problem? On this one, what do you worry about the patient, for the patient's health? Clotting too much, okay? What do you worry about if they're way over 3 all the time? Bleeding, okay? And a lot of times we saw it as a nosebleed. They'd come in with a nosebleed, they couldn't stop. The one man I saw that was the worst, he didn't even have it over 5. You'd think, oh, I bet your INR is over 5. And it was 3 to 4.
So you
Yes.
said 3.5 was lit, like
2 to 3 is what you want them when they're first on Coumadin. So you got it. That's what you got to know for your test. So you're going to have to know how to calculate an INR. You're going to have to know what it means for the patient. They could clot more, or they could hemorrhage, or have extra bleeding. And what are the doctor's options? They can drop the medicine if it's too high, or if it's a panic one, what do you think they can do? If it's above 5, fast-acting vitamin, they can give them an injection of vitamin K. If it's a panic one. If it's just right around the 2 to 3, they're not going to automatically go to giving them a dose of vitamin K. So when it's below, you want to think, oh, you could have a problem with clotting, so they might have to up the dose or adjust their diet. If it's close and they can't seem to get into the 2 to 3. And if it's above 3, like 3.5 to 4, they're probably going to just lower the dosage. You know, they're not just going to jump to giving them vitamin K. So that's what you got to know for your test. So there's some key things, you know. If you work in a small lab, let's say you work at the Urgent Care and they don't have a machine, they have one like the MLA 750, you have to find out the ISI off your thromboplastin, and you got to use your mean of your normal control, and you've got to calculate it and report it. So every facility will report an INR even if your machine doesn't have it set up in it. So you need to understand that as a tech, how to calculate one. So on this test, you will have to calculate one and know the 2 to 3, okay? Because that has been a savior of patients, because the physicians, no matter where they work, knows. So there's something off every one of these you got to know, okay? So when I refer in your review sheet for next week's test, the handouts, these 3, there's something, every one of them you have to know on your test. And there are 3 different books, so I liked Turgeon a lot, and I had never really, for some of it. So, okay. And what's the reagent in the proton? Thromboplastin with what? Calcium, because calcium is depleted, taken away from the sodium citrate. And a normal, usually your normal control range is 10 to 13 and your normal patient range is 10 to 13. That doesn't always happen that they're similar. A lot of times your control range is a little different from what your normal range for your patient value. Okay, now you should know the PTT sometimes is called activated, so it's one and the same if you see APTT or PTT. And I don't care if you know it's activated partial thromboplastin time or partial thromboplastin time. They're one and the same. Just some people refer to it as the activated. So that should give you a clue. What are the two reagents and what does the first one have? If you understand the A part, that's what the first reagent has. So what are the two reagents in this test? There's only one for the proton. So either our reagent was called actin, but sometimes you just call it the PTT reagent. And what's the key thing it provides? It's an activator to mimic collagen. So in vivo, it's collagen that gets 12 going. In your little vial, the activator that mimics collagen, they can use different things. There's ellagic acid they can put in it. There's a thing called kaolin. There's a thing called cellite. If you read the bottle or the insert, it'll tell you what's the activator. For me, you just have to know there's an activator. And then what's your second reagent? The calcium chloride. So somewhere in both proton and PTT, you have to add back the calcium. Okay? And that's why if you understand how your citrate works, you understand that you got to add calcium. And we'll go for the normal is 28 to 36 seconds. Like my first time when that girl had von Willebrand's, our normal was less than 40. Every lab will have a little bit different range for their normal controls because they have to establish it with those 30 days ran by all shifts. Like we did in 150 when we did the proton range. Every lab has to do that when they get a new lot number in. This is thrombin time. I'll only have you know a couple things just because of the registry. I don't think you're going to see it there, any lab, because one thing I want you to know, underline this sentence, affected by heparin. That's why it is not a very useful test. If your lab does not have something to remove the heparin, if they don't have something to remove the heparin, it's pointless. You say, I know it's going to be elevated. It's not going to be in 12 to 18 seconds. They're on heparin and we don't have anything to remove it. Okay, so I want you to know 12 to 18 seconds is the normal. It's for factor 1. It's a screening test for factor 1. So all you tell the doctor, well, it clotted at 15 seconds. He says, oh, they have a normal factor 1. Did you tell him how many milligrams per deciliter? No. So the fibrinogen test that we did, the factor 1 assay, is much better. It's not affected by heparin, and you give them the exact amount. He won't have to say, oh yeah, they're normal. They clotted 16 seconds, and normal's 12 to 18. That's all you can tell him here. Yes, it clotted in the normal time. When you added thrombin to the plasma, it acted on factor 1, and it formed the fibrin clot. So the biggest problem, it's affected by heparin. And we had Heprazor, but we only used it for the certain doctor that wanted it. So it's a screening. Is the factor 1 assay, the fibrinogen, a screening test? It tells you exactly how much you have. It tells you a confirming amount. They have 250 milligrams per deciliter. This person has 390 milligrams per deciliter. All this says is, oh, they clotted in 13 seconds. Well, they have enough, but I don't know how much. So if they want to know how much, you got to follow this up with a fibrinogen. And why do this if so many patients in the hospital are on heparin when you can go straight to the fibrinogen? I don't think you'll see this, but you'll see it on the registry. So it's a screening test for fibrinogen that is very much affected by heparin. They do, remember how I said snake venoms can start the clotting process at different, when we review for the test, we'll go over snake venoms, how they can trigger DIC. There's a test they call reptilase. So I just want you to write this down. Reptilase is just like a thrombin. I'll call it TT, thrombin, but it is not affected by heparin. I don't think you'll see either of these tests, and for sure not the reptilase, but I want to see if you understand it. I come from heart surgery. I'm on heparin. The doctor wants a thrombin, and I say, well, we'll do that, but we also have a reptilase test because it is not affected by heparin. And so I'll show you their results. So the thrombin time was 24 seconds. The reptilase time was 15 seconds. What is the patient problem? If you understand what I'm telling you about thrombin time versus reptilase. The heparin is affecting the thrombin time because the reptilase was between the normal 12 and 18 seconds. So let me show you this. I get my patient that is just finished heart surgery. The thrombin time is 24 seconds and the reptilase is 24 seconds. Now what's the problem? The factor 1. Reptilase is not affected by heparin. So the good thing about that test, if it's elevated and they come out of heart surgery, that doctor better probably be giving them FFP, or you'll learn of a thing called cryo that has factor 1 with blood bank, or they can give them, I don't think there's any concentrated factor 1. So if it's a pretty good bleed that patient might be bleeding after surgery because their fibrinogen is truly deficient, they're going to be given not maybe only hanging blood, but hanging fresh frozen plasma. So this is something I've seen on a registry, that you understand why reptilase test. I don't even think you're going to see a thrombin time. But remember, snake venoms can trigger clotting. So the reptilase is kind of something from a snake venom, and it's not affected by heparin. So so we chose to not do the reptilase test. We used the powder to remove the heparin. So then that mimicked doing a reptilase that wasn't affected. So this one we know factor 1 is low. This one we know it's heparin. So that's what I've seen on the registry. The question I might ask you is, what mimics a thrombin time test but isn't affected by heparin? And that would be your reptilase. So I would write that on that slide so they all stay together. Like I said, I don't think you're going to see it anywhere in the real lab, but it's still on the registry, the thrombin time. You already know the fibrinogen. So what was our control for our lab on the fibrinogen? It was 220 to 280. So for our fibrinogen test, we'll put these up here. Pro time 10 to 13 milligram per deciliter seconds. PTT 28 to 36 seconds. BT 2 to 9 minutes. Platelet count 150,000 to 400,000 platelets per cmm. Okay, thrombin time 12 to 18 seconds. So somewhere I'd be writing all these down, because this will be test 5, but you got to know your normals. Okay, fibrinogen is better because it's not affected by heparin. We know that the control was 220 to 280, but a patient is 200 to 400. Anybody remember why your fibrinogen can be elevated? And I'd write that on the slide. Anybody remember? You had asked the question in lab. There's something you'll learn in serology that fibrinogen is when there's infection or inflammation. Your fibrinogen, you're going to learn a term in serology called an acute phase reactant. So what I would put is level 1 can increase when there is an inflammation of some sort, and usually if you have infection, there's inflammation. Gets that real reddened area. Diane will go over inflammation and phagocytosis, and that's one of the first things you'll learn is that fibrinogen can elevate when there's an inflammatory condition. So, yes,
Is that fibrinogen or is that
level 1, that's the same. One is fibrinogen. So no one back and forth, okay? And what was the key difference of the fibrinogen versus in the ProTime and PTT? What'd you have to do to the patient plasma or the control? Make the dilution. You didn't have to do that in the ProTime, you didn't have to do that in the PTT. The nice thing about the new analyzers out there, they make it for you. So I think you'll see, you understand things better if you have to do some of the precursor methods, because you're going to put a tube on. Some of them you don't even have to take the cap off because they're cap piercing. You put the tube on a rack, press the button, and like we said, if it's normal, if they have auto release, like at Christian, the person who puts it on, no one else might ever see it because it even goes into their storage refrigerator and it goes straight, the results, to the floor. So they only have to even physically send to the floor the abnormal ones. That might be 80% of your departments, all normal, and the only person that did anything with the specimen is they put it on the rack. So you're gonna understand more from here than you'll see there. Now, D-dimer will be part of your test tomorrow for DIC. So you tell me, what should the D-dimer normal be? Negative. And tell me what it tells you when you don't have them cleared by the liver. What is happening in your body? Clotting. So there's two kind of things you'll know. You'll see them ordered in ER. Anybody who has a deep vein thrombosis, has a pulmonary embolism, has a heart attack, has a stroke, they're going to do a D-dimer and see if they have excess D-dimers that aren't being cleared, because they'll be elevated when they do that test. I think you're going to see that most of all. Who just was it you, Krista, that you said you saw a DIC on one of the TV shows?
Yeah, on Grey's Anatomy.
And it was a pregnancy problem with the placenta pulling away. And that's the other case. That's, I mean, the true case I saw. And it was releasing factor 3. So remember what else can trigger DIC as an example? I gave you 3 examples. The placenta pulling away is a release of factor 3, so it triggers the extrinsic system. Do you remember? What?
Did you go by factor 3 and?
What triggered or activated factor 12? Anybody remember? They give sepsis. Any gram-negative infection sometimes activates and gets the intrinsic system. And then what did we just talk about in this test? What affects clotting directly? Your snake venoms. So snake venoms can act on 10 directly. It can go act on 2 directly. It can go act on 1. I think if you see one, a real one, it might be a pregnancy problem, that you're going to see factor 3 being released. And remember, disseminated intravascular coagulation. This triggers widespread clotting. It's not localized. And so when we go through the results you should expect, the D-dimer is a key result. Does anybody remember what the second key result happens when you have clots everywhere? There was a ProTime, a PTT, a platelet count, a fibrinogen, and a D-dimer. Do you remember what the other one separated it from primary? And we're going to review that. What is used up when you're forming a clot in primary hemostasis?
The GP.
Platelets. Form the platelet plug, and the clotting factor joins it by way of PF3. And so you're going to have low platelet count when you're having a DIC. You're going to have a normal platelet count and this we'll review because that's on your test. D-dimer is a big deal to prove clotting. And it doesn't have to just be with DIC.
Wouldn't D-dimers couldn't it be an indication of liver?
I don't think liver failure, they don't produce the factors. I don't think they're breaking down, in liver failure, I don't think they're breaking down fibrinogen or breaking down the fibrin clot. They're not producing the factors, so you don't have
The liver's
enough.
not cleaning up the D-dimers either. Oh, so the liver's the one, never mind. I remember you saying that, never mind.
So, and I mean, I think all of you will see a DIC case, even if all you do in your lab is protimes and PTTs. And you'll know it, and this is the case where I had, where the fibrinogen went sky high, platelet count bottomed out, the protime and PTT were bottomed out, but the person had inflammation going on as well. So that's why the fibrinogen went high instead of low. We're gonna learn it as low, yes.
What did you say factor 12 was?
In the intrinsics, sepsis. There's a whole list of things that trigger DIC, and I'm only talking about acute DIC, you usually hemorrhage. You can have a chronic DIC, like the lady I told you who threw blood clots in her extremities from a routine surgery. She had a chronic DIC, and then the clotting overwhelmed everything, and she had blood clots everywhere. She didn't have the degradation product, she had blood clots everywhere that triggered the extremities, having to cut off some of them. So I'm only having you know acute. And we're gonna know the platelet count is low because we don't even have serology yet to really add to the picture. You remember what I told you about a factor 13? Yes.
I'm sorry, this is slightly off topic, but liver spots, are those actually bruises, not discoloration of the skin?
I don't know. I really don't know. I guess you could Google it. I'm not really sure with liver spots, I don't know. I would think so on an MRI or a CAT scan, they would probably worry about something suspicious looking being cancerous.
Well, no, when liver spots are what you see, they look like huge freckles on the elderly.
Oh, you mean just the brown?
Yeah.
I have plenty of them. I don't know. I don't really know, technically, if it has anything to do with the liver, as far as the brown spots, the pigmentation. But, anybody remember how you know it's a factor 13 deficiency?
If the clot dislodges.
Tell me on the ProTime and PTT first, because you're going to have to know this for tomorrow's test.
They're both
Normal. So this is the test that you do to confirm. And what is the symptom the patient has? You have to have a symptom that the patient displays before they're going to order this test. What do you see of the patient? So what happens? That you can clot without 13, it stabilizes it. So what do you think would happen to a patient who just had surgery? It's a delayed bleeding, and a lot of times it's not the first 24 hours, but you get to 36, 48, and they're going to start oozing at their suture site. So what they do, there's urea reagent. Some of them call it urea clot solubility, some call it for me, I'm just going to call it 5 molar urea. And you put like a mill of it in a tube. You see when we did the fibrometer, you could take that clot off the end of your probe, stick it in the mill of your 5 molar urea, and then come back, then note the time, the next day, look at it at 24 hours. If it's completely gone and all you see is the liquid, they're deficient in 13. If the clot is still suspended after 24 hours, you know 13 is not their problem. This is its hallmark test. 5 molar urea is abnormal. ProTime and PTT are normal. For every factor, you're going to have to tell me what is abnormal, ProTime, PTT, on every one. Because by knowing your systems, you should be able to tell me increase, normal, increase, depending on what area. So if I give you factor 13, you're going to put normal. Okay? And then what would you confirm it? 5 molar urea. It would, I'm sorry, what?
Do you know why the clot forms between the two?
That's the electromechanical. Even on the balls, it says the turbidity forms with the balls that it senses. So much clot gets formed around the balls in the start 4. That clot is forming between those two probes. And especially the longer you let it sit. That used to be the only types of machines when I first started with electromechanical. Then they started advancing to the optical density. The optical density have an issue. Do you know what lipemic and icteric means? What does your serum or plasma look like if it's lipemic?
White.
It's milky. If it's icteric, it can kind of be a brownish color sometimes, or a yellow green or a green. If you're on an optical density machine that, like the MLA 750, you'd have to, if it was that milky, the machine might not be able to detect a clot because it's already so hard to get light through it. The machines now are so good, you don't have to do a second analyzer. But the 750s, if you have a lipemic or a very greenish yellow, you better have a backup, like the fibrometer, to do the ProTime and PTT. It'll give you abnormally high results, and it's all because of the color of the plasma. So now the machines are so good, I don't know anybody, even if it's optical density, has any backup because it can detect the slightest change. But this is the classic test for 13. So if you know normal protein, normal PTT, abnormal 5 molar urea, that sums up 13. Oozes after 24 hours. So that's one of them you don't have to know a lot about. But that's like, and it's not a trick question, it's a valid question on the registry when they ask you about factor 13. Because they'll give you a list of results and you'll say, wait a minute, they're all normal. And then they have to say how did they confirmed it, and you'll see that's abnormal. Okay, this is the key piece, and I think this is the last thing. Now you need your syllabus. I think you guys are gonna be good. These are fun when you get it. And you seem to get it when we talked about correcting factor 8 and 9. So, I wanted to point out, you have examples starting on 66 that show you, and I even give you real examples. So you have something to refer to after today. This is all test 5. You have a lot on test 5. Tomorrow test might not even be a half hour. You'll have a ton on test 5. You want to go to page 69. Okay? Now you got to tell me all the stuff you know about the clotting factors. And we're going to put it on the board. And then I'll see if anybody wants to try to volunteer. I think you guys are going to get this because you seemed pretty good when we did factor 8 and 9, what was corrected. So I think you guys are going to be good. So normal plasma has what in it? And that has to be the first step of any mixing or stuff. And I put it as both, I call them substitution studies. A lot of places call them mixing studies. They're one and the same. What does the extrinsic factors? Three.
7.
Intrinsic factors.
12, 11, 9, 8.
And for this is the test, you're going to want to write all this on your front page. Test 5, you want to, and put on here test 5. And then what's absorbed plasma have?
5, 8, 11, 12.
And a serum.
7, 9, 10.
Okay, let's look at our first scenario. We'll do the first one together and see if you get the hang of it. First one's easy. You got to know your normals, right? Because I give you the seconds. So tell me if it was 15.3 and the PTT is 30, what is normal and what's abnormal? Okay, is everybody okay with that? The first step in every one of a substitution study is run with normal plasma. So, my corrections are gonna be, they go to normal range. The true definition of correcting, when you can put a C if it corrected, is if they get better by 50%, okay? So, it was patient plus normal plasma was 12 seconds. Did that correct the ProTime into normal range? if really, especially when we're doing PTTs and you get very high values, if I had an 80-second PTT and I gave you the value with normal plasma was 40 seconds, that's a correction. Even though 28 to 36 is normal range, it got better by 50%. It went from 80 to 40, that's a correction.
Okay.
On my test, they're going to be in the normal range when they correct. So the first thing you want to do is put corrected. This is the step that is critical, and I see this on the registry question. It was corrected with normal plasma. What does it tell you? If it has all the factors in normal plasma, it had to provide the one that was missing. So it's a factor problem. What happens if this was 15.3 seconds? And you'll understand that better after tomorrow's lecture. It's not a factor. You don't have to do any more testing. You gotta look elsewhere. But I give you this scenario just so you get to see it does correct. On the first 3 examples, we're gonna get through those today. The 4th one goes with tomorrow's lecture. So, how do we know what corrected it? You all know because 7's the only one in the extrinsic system only. But we're gonna prove it. Patient plus absorb, and this is, I'll write my PT as big PT, I'll write my patient as little PT. Patient plus absorbs was 15 seconds. Patient plus H serum was 12 seconds. Which one corrected? So this one corrected. Did this correct? And what is in H serum that corrected the problem? We knew it was a factor because it corrected with normal plasma. So what is in H serum that made this be the normal range?
7.
Factor 7 is in H serum. And you guys could have told me without doing this because you know that's the only isolated factor when it's a protein. So this is the easiest scenario. So you know you can tell the doctor it's factor 7. We know 7's the only one in the protein. We know we didn't have to do any of this because we know that's the only factor. But you can't say that when you get to the other 2 scenarios. So I want you, and don't worry about, the first question, what does it mean if it does not correct with normal plasma? It is not a factor. So at least write that. Is further testing needed? Yes. And what action? You'll know more tomorrow when we get into next lecture. So I want you to do 2 and 3, and then I'm going to put them on the board while you're doing them. And I want to see if you can do 2 and 3, page 70 and 71. Don't worry about the questions. Just see if you can do the top part of 2 and 3. You have everything you need, those 5 things up on the board. And I'll put them on the board, and then we'll end there so we can review, and then I'll give you some other scenarios tomorrow. I don't even have, that is weird. I have to give you number 2 to write on. That doesn't make any sense. I'll give you the scenario up here because I don't know I didn't change anything, but it didn't copy even over. Okay, I'll give you the scenario. This is what it's supposed to be, so if you'll write that in your book. So write these results in your book, since I don't know. I'm hoping it did fine on my next page, but I don't know what happened on 70. Okay. So that was example 2. So make sure you put those results in here. Correct. Unknown 3 is okay. And we'll go over these more tomorrow.
So this here it is.
I love this one on number 3. Jen, you have to write the results, the initial results for unknown number 2. It's not correct in the book. Unknown 3 is okay. And there's lots of scenarios other than these 4, and I'll show you some, I'll show you more after we go through these, and then we're just gonna take the rest of the time and review. And I'm not gonna put the answer to this one, I wanna see if you get it. Okay, let's start with unknown number 2. The pro time was 11.3 seconds, the PTT was 52 seconds. Does everybody have normal for the pro time and increased for the PTT? Okay. Anybody tell me on this one why I ran the pro time on these 3 specimens? Because that's a big deal, understanding what you run. I just make 50-50 mixtures and you put all 3 specimens on and run the pro time. Why would I run the pro time on the first one? You run what is elevated. Do I need to run PTTs? The PTT was normal. You don't run something that's not elevated on your 3 mixtures. When I make this, I'm taking equal amounts of patient plasma and equal amounts of a vial of normal plasma. Here I'm taking equal amounts of patient plasma and a vial of adsorbed plasma, equal amounts, and I mix them. And then that's my patient. Then I run 3 patients, they're my patients. I run the pro time because that's what was elevated. Can anybody tell me in example 2 why I run the PTT? What was elevated? The PTT. So what happened? It corrected with normal plasma because it was between 28 and 36 seconds. So that tells me it's a factor. You already know if it's elevated with the PTT only. You told me it was 12, 11, 9, or 8, right? Now I'm helping you use a tool to tell me which one it is. We're taking it a step further. So did this correct? Adsorbed plasma. So that eliminates those, right? If those don't help and it doesn't make it any better, you eliminate those from the normal. So what was in age serum of these 4 factors? Factor 9. If it was factor 8, what would have corrected? This would have corrected. Remember, that's how we distinguished hemophilia A and B on your last test. It would have corrected here 32 seconds, and this would have been 50. How would you know if it was 11 or 12? 11 and 12 are in both, right? So it should have been normal PTT, normal PTT, and you'll say, well, that only gets me down to 11 or 12. That's when the doctor orders a factor assay. And which of 11 or 12, do you remember from last test, what bleeds and what thromboses or has no symptoms? Which one? Hemophilia C is 11, it will bleed. Factor 12 is the one that's asymptomatic or thrombosis. So your patient history might tell the doctor, well, I bet it's a factor 11 of those two. And he'll order a factor 11 assay. So you've got to be able to use what corrected and not corrected. You already know to this level. You were able to tell me, well, if it's PTT elevated only, it's 12, 11, 9, or 8. I'm just showing you how you tell the doctor which one it is. You already know to this point. You've already been tested on that. Okay, over here, why do you think I ran the pro time? Run the easiest test. They're both elevated. You could have run the PTT, but run the shortest, easiest test, because then you'll be done sooner. So we always ran the pro time, because we used to do this test. We always ran the pro time. So what does it tell me when it corrects with normal plasma? It was 10, 5, 2, or 1. So, did you notice it didn't correct with either adzoroplasma or H serum? So what is it? Look at 10, 5, 2, or 1. What is it in either reagent? 2. What would have happened if it was factor 10?
Corrected H serum.
It would have corrected here and not here. What would have happened if it was 1 or 5? It would have corrected with adzoroplasma and not H serum. Okay, this is a big deal, you guys, because this tells me you get it. And this is just our first exposure. This test is until next week. But I wanted to start it today because you're going to need a little time. Some people get it right away. But this is where I ask. Some of you help each other because sometimes people won't come for me for help. Okay, so this is where we've led to. If you understand your clotting factors, if you understand this, you understand your clotting factors. And I wanted to get exposed to first. I wasn't going to do this lecture till the third one we have left. And I thought I'm getting this done first so we can practice each day. Okay? I'll give you 3 different scenarios tomorrow, and we'll try to do a scenario each Wednesday and Thursday, and hopefully by Thursday. But do you see why you want to write these on in front of your test? You don't have to think about it, you can just use it. This is my recommendation. You get test 5, which is next week, you write those 5 things down. Okay? Then you just refer to it. And remember, normal plasma is the key to understanding the first 3. Tomorrow, I'm going to take you to the sample 4. Because right now, all we're worried about is the factor. Okay, so let's look for tomorrow's test. Your test isn't over a lot, but we couldn't get enough done, and I